This is my first time here at the VACCS, but thank you for that intro, and I'm super excited to be here just because I know it's a Saturday, and so I'm impressed that you all showed up. I guess the rain went down, so it's a little bit easier to get here, but I'm very excited to be here. So what I am is a thoracic surgeon. So as a thoracic surgeon, all that, for this talk, you have to think of it as I'm the lung surgeon, okay? So if we see something or catch something, I'm the one that we remove it, or figure out what to do about a lung nodule. So that's kind of where my role is in that, if you're wondering what a thoracic surgeon is. And so yes, I mainly operate, I do all my surgery and clinical practice in Kaiser in Oakland. That's our main base for lung type surgery. And then you see these other things. I do stuff at UCSF and Kaiser School of Medicine. So UCSF, you know what that is. Kaiser School of Medicine actually is in its 4th year, believe it or not. It just got accreditation, so they are in their 4th year, and they're in Pasadena. So if you start to, now Kaiser has their own School of Medicine, if you didn't know that. So the other thing I wanted to say that Ago was reminding me of is I do want to try to make, it's a Saturday afternoon, you guys came all the way out here, we should try to make it as interactive as possible. And I'm not going to go till 4:30, right? We have the room till 4:30, but I have about 40-45 slides, but please stop me in between if it's not getting to the point where it's getting home to you guys, or if you guys have questions. Because like I said, this is not live or on Zoom. This is just you guys, so I appreciate that. All right, so let's start off, right? The way I'm gonna do this, the way I do this talk, the way I think it brings it home the most, are these are real people, right? These are your friends, these are my friends. I've had family and friends affected by this. Yes, I'm a Japanese male, talking about lung cancer in women, but I've had family members with this, and that's the patient population that I see. So hopefully that'll come across to you that it doesn't have to be just women talking about this. This is what lung cancer is. It's a disease of women. So Christy was in her early 40s. That's her husband. Her husband is a sheriff in the San Francisco Police Department. These are her 3 kids. She, as you can see, she was one of my patients afterwards. She was initially diagnosed with stage 4 lung cancer after having symptoms. So diagnosed stage 4, later stage disease. She fought it for about 2 to 3 years, lived a lot longer than people used to live with stage 4 lung cancer, but eventually passed in 2022, again at the age of 45. So this is very near and dear to my heart, and so Christy was a big advocate, and her kids, you can see her 3 kids there. I'm not gonna do everybody, right? But this last one is the reason why I bring this home is Barbara Kitagawa. She's, she was 75, Japanese-American female non-smoker. Again, we're gonna be talking about a lot of non-smoking people, but it's not to stigmatize smoking, it's just to say what we see in Asian women, which if you actually poll Asian women here, there's only 3% of the Asian women that if you poll actually do smoke. So when we talk about Asian women, it's a cultural pattern to really assume that they don't smoke. So when we talk about lung cancer and that, yes, there are some Asian women that smoke, and it's okay if you smoke and all that, but we're mostly going to be talking about the non-smoking population. So Barbara was a non-smoker. She lived for 12 years. So it was great. We caught it early. She literally was gonna, I don't know, no, Donna's not here, but I was giving a talk to notify the Japanese American population. I don't know if you've heard of the group JSA. They're in Emeryville. And we held a little seminar, and she was set to come to the seminar, and this was 6 months ago. The day before, we got a call saying that she passed away. She was totally fine, doing fine, she was in remission, but she passed away. And we don't think it's from lung cancer, right? She had been doing well for 10 years, but it just goes to show that you never know, and she was a big advocate too. So it's kind of like the point is that Christy and Barbara were advocates, but not all advocates can survive forever. Some do survive for a long time, but many don't. And so you don't hear their voice, right? If they pass, and then we can't propagate that on. So hopefully we can propagate what they represented to you all, so we can keep going. Okay, so to start it off, I want to talk about lung cancer just overall, just real quick, just basic facts about lung cancer that may surprise you a little bit, I think. So hopefully these will take home points, just the very basics. And then I want to talk about lung cancer in women. Regardless if you're Asian, Black, Hispanic, whatever, lung cancer in women, it's a different disease process than men, okay? It's different, and that's what a lot of people don't realize. They think lung cancer is all the same. It's very different in women, and we're going to go over that. And then I think hopefully some interesting parts, as I've done more research about Asians in the Bay Area. I'm from Walnut Creek, and I'm fourth generation Japanese, so I've been around a long time, and I didn't realize how big the Asian American population is. Now it's including everybody, South Asian, East Asian, everything, but I'm going to give you some numbers and to really hopefully it'll relate to you all. And then we're going to get really down and dirty to the hidden disparity, hidden health disparity, lung cancer in Asian women non-smokers. Okay, and I'm going to talk about some of the risk factors, what we can do to help, and then just interrupt me if anything comes up to you. Okay, so lung cancer is what all cancers, all you have to know is that the most common in women is breast. The most common in men is prostate. So everybody thinks about, when they think of women, they think breast cancer, right? But if you didn't know that, lung is actually second most common, okay? In both men and women. And then this is what you need to look at. But what do people die of out of all the cancers? It's not breast cancer, it's lung cancer. Lung cancer is the #1 cancer killer in all women, okay? And then we're just talking overall, men and women. Okay, so we really should be talking more about lung cancer, but why don't we, right? There may be a stigma associated with that. You smoked, you deserve it, you want to hide it, things like that, which is not always the case. It's never the case, but regardless, I think that's what we're trying to get this awareness out, that lung cancer is not all just related to smoking, and it's not, most people that smoke do not get lung cancer. So why do we not talk about this more? We'll get into that. So what's the 5-year survival overall? This is not to play Debbie Downer, but this is to realize why, so 5-year survival for all stages. Now, this is if you're diagnosed early or late. So Christy or Barbara, put them together, all comers, the chance of you being alive in 5 years is 25%. Okay, that's the issue, right, that we're dealing with. It's gotten better. It goes up 2% per year. It's gotten better. It was 20% a few years ago. So we've gotten better, but you can still see it's not great. But the reason why I show this slide, and again, this is an Asian group, and it throws people off this way, but Asians, when they do get diagnosed with lung cancer, you do have a better prognosis. And we're going to get into why I think that some of that is, and we're still trying to figure that out. But just Asians overall, if they do get lung cancer, they do better survival. So I want to try to say there's for every good or for every bad, there's also good. All right. So what are so just this slide kind of tells it all. I don't have to read the breasts or the blue painting, but right, when we think of women, we think of breast cancer. But if you actually look at breast, colon, and prostate cancer, those still don't kill more, lung cancer still kills more people than breast, colon, and prostate all combined. And if I told you that lung cancer, I told you that 5-year survival is 25%, would you believe me that breast cancer, all comers, stage 1 to 4, breast cancer, 5-year survival, for even stage 4 to 1, or 1 to 4, it's over 90%. And even colon cancer, 65%. So don't get me wrong, those are dangerous. You hear about the colon cancer right now, right? All the younger people are getting it. You hear all of that, but in reality, it's lung cancer that you're going to die of, right? I'm not saying it's good to have those other cancers, or they're better, but they do have a much better prognosis and survival than people with lung cancer. And then how about if I told you this? This is all the United States. I'm not talking in Asia or Russia or Korea. I'm trying to bring this home for you all. You guys are in the United States. Whether you're born here or not, more than 50% of all lung cancer now are people that are not currently smoking or have never smoked. Okay? So this is not just you smoke, you're going to get lung cancer, or if you don't smoke, you're not going to get lung cancer, right? That's very far off. The smoking is just a small part of it now. Okay, so men, I don't have a pointer, but men is in red, right? So men, lung cancer is decreasing. So that's the other problem. Everybody thinks lung cancer is going away because a lot of men, you don't see the Marlboro man anymore, right? They don't get lung cancer anymore, right? Because it's like very different. But women, it's not decreasing. This is overall, all women. It's kind of staying steady, just overall in women. And why is that? We're going to go into that. So all you have to look at here is the percent of lung cancer. So the majority of lung cancer, meaning 46% of all lung cancer cases in the United States, they're diagnosed late stage. Where we know the survival is bad. 7% survival if you're diagnosed late stage in 5 years. Versus if you're diagnosed early, which is only a quarter of the population right now in the United States, you have already automatically, it goes up to 61%, right? So how do you catch that early? Screening is one of them, but Asian women don't count for the screening. So we're gonna have to go into that in detail, how we're gonna combat that. So let's talk now about a little bit more just about women. And, right, I realize not everybody here are women, but women, it is different in lung cancer. So when women have lung cancer, it's usually a type called adenocarcinoma. Very different than small cell. Very different than even squamous cell. Most women especially Asian women, have what's called adenocarcinoma, which is just a different type of lung cancer, and it's usually a slower growing type of lung cancer. Women are more than 2 times likely, whether you're Asian or not, to get lung cancer as a non-smoker. And in fact, hopefully in 5 years we'll have this. Right now at the NIH, when I say for you piano players out there, right now they've done a study on non-smoking women, and they're called genetic subtypes. They took 75 women that had lung cancer, and they took their blood, they looked at their DNA, and they looked at they found 3 differences. So if you're the slow-growing lung cancer, right? If you're just based on the blood, on the DNA fragmentation, if you're slow-growing lung cancer, you're called piano. If you're the medium fast-growing lung cancer, like the medium kind, you're a mesoforte. And then if you're the fast-growing lung cancer, it grows in a month, spreads everywhere, that's forte, right? We don't have that prime time yet, but just imagine if you get lung cancer, or you see a lung nodule, you don't know it's lung cancer yet, and you get a blood test, they test your DNA based on DNA and RNA markings and protein markings, and then they can tell you how fast that nodule or what type of cancer you have. Meaning, you'll know the cell type, but I mean because everybody wants to know, was it gonna grow? How long has it been here? Well, imagine that in 5 to 10 years, we may know that. But until then, we don't know that, right? And so when I see a lung nodule, I don't know, that could be cancer right away. And so that's what I'm trying to educate you on. But until we get to what this piano, mesoforte, and forte, we gotta do other things, right? That technology is not there yet. Women get lung cancer at much younger age. The average age of lung, do you guys know what the average age of lung cancer is currently in the United States for men and women? Anybody guess? 71. That's the average age of people that get lung cancer. In women, it is lower, but the average age is 70. So in women, they get it much younger, in their 50s. And when women get it, they often will have the family history of cancer. Okay? So this is gonna be a theme. Family history. And then actually women, not just Asian women, but women, I told you Asian in general, just Asian ethnicity, men or women do better prognosis-wise. But women in general do better as well, just being a woman, regardless of what race ethnicity you are. They've done studies on that. Women that have had lung cancer versus men, and they've adjusted for all these other factors, regardless, survival's better. Okay? So I'm telling you there's something different in the genes of your lung cancer, which is a good thing, but you're also getting it more often than men. So it's kind of good and bad, right? So again, a good thing and a bad thing, and we're gonna try to combat that, get solutions. Okay, so hopefully this video will play. This is an awesome video, I think. I still play this. This is from...
It's time for a health quiz. What form of cancer causes the most deaths among women? If you said breast cancer, you're wrong. It's lung cancer. This disease declined steadily over the past 3 decades among men, so why has it doubled among women? Doctors aren't sure. They think estrogen plays a role, but a lot more research is needed, and that costs money. Yet a report by Brigham and Women's Hospital calls lung cancer the least funded of all major cancers. That may be because we sometimes blame lung cancer patients for their conditions, assuming they got sick because they smoked. While more than 90% of men with lung cancer smoked, 1 out of 5 women with the disease never smoked at all. Either way, the cause shouldn't affect the cure. 250 women are diagnosed with lung cancer every day, and most die within a year. We need to put aside the blame game and figure out what's going on. That's a page from my notebook. I'm Katie Couric, CBS News.
Okay, so we all know Katie Couric. So does anyone want to guess when this was? It's a hint on the slide when she did this. It's 2010. That was 14 years ago. Or what do I? That's 14. 14. Yes, sorry. It's been 14 years ago. She brought this up about women. We've known about this for 14 years and even more. I don't want to shock you guys, but we actually started talking about this in 2005. But here we are 20 years later, still dealing with the same thing. Luckily, the only difference in what she said now versus then, the only thing that's changed is that if she said that statement, well, most women will die within 1 year, that's how it was in 2010. That's changed because of all the different medications we have now for stage 4 disease and the genetic markers that we have, the targeted therapy that you hear about, the pill therapy or immunotherapy. So that's the only thing that's changed though. The research, remember she says research is the least funded for lung cancer? It is still the least funded lung cancer. It's still the least funded cancer out of everything, still. So again, we haven't changed that much. So we need to do more. Okay, So now let's go into, so any questions about that, about lung cancer in women, lung cancer? Pretty straightforward, right? I know you guys want to get to the meeting coming up. Angie?
Can you talk about what's the difference between early stage diagnosis and the late stage? Like how many stages are there? You know, like...
So there's 4 stages, 1 being the best, meaning the earliest stage, you caught it where it's just a little nodule. Then 2 kind of spreads, gets a little bigger, goes to lymph nodes. 3 gets even bigger, and then 4 spread to different places in the body. Okay? So 4 is later stage, where surgery may not be as big of an option. Radiation may not be as big of an option. That's where you hear people on chemotherapy or targeted therapy. So the earlier you catch it, which is usually when you don't have symptoms, which is through screening, is better because you catch it and it's really localized. And then somebody like me, that's all I do. I chop pieces of lung out all day, right? Minimally invasively now. So we can do that in an hour and you go home the next day, right? So imagine if we could do that just where you catch it early, chop it out, and you live a normal life, right? But if you catch it way later, where you can't do it, where it's here, 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 and surgery's not gonna help because it's over here, I can't just cut out both lungs, then you have to go on what's called the targeted treatment, or what we're gonna go into, is chemotherapy or immunotherapy and all that. And yes, it can shrink things down because what we're gonna get into, you have biomarkers in your blood that we can test that can go for certain targeted, personalized medicine drugs. And so that can slow things down. But they only usually last for about 2 to 3 years. And then the tumor mutates. And that's why you're hearing on the news all these new drugs. Then you get a new drug, which is good, keep you alive for another couple of years, and then you'll mutate, recur, and then you gotta figure something else out. So the longer you stay, the goal is though, the longer, for your friends out there, or people that you may know, the longer they stay alive, the better, because we're getting better and better. And I'll tell you now, for stage 4 disease, we add surgery now. So we have friends out there, right? Stage 4 disease, oh no, we can't do anything. Yeah, we can. We can do surgery now. That's my job to kind of talk about that. So yes, stage 1 to 4, 4 being later. You want to catch early when you're not having symptoms. When people are having symptoms, weight loss, chest pain, cough, that's you, and you get a scan, it's usually going to be stage 4. That's the problem, is that most people catch at stage 4 because we don't do a big job screening in the United States for lung cancer. But if I ask all you about mammograms, you guys all get mammograms, right? You guys all get your colonoscopies, or if you don't get a colonoscopy, because I hate colonoscopies too, you get your FIT test, the whatever, poop on a stick test, right? You get your cervical pap smears, that's no problem, right? We don't do a good job of lung cancer screening. Lung cancer screening is covered in the United States. Anybody from 50 to 80 years old, male or female, if you have a smoking history of at least 20 pack years, which makes it more complicated, right? And you quit within the past 15 years, all that you have to calculate in your head, right? And if you do that, then you do qualify for getting a CT scan every year. But if you don't, if you're not in that age group, or you don't have a smoking history, there is no screening test for you right now. Okay, cool. All right, so this is Susan Shinagawa. She's an advocate for Asian Americans. So I want to talk to you guys about it being Asian American in the United States, and then I'm going to bring it home to the Bay Area. These are things. Now, this is all Asians, right? South Asian, East Asian, right? We're all one big happy family, even though we all know there's so many differences between all of us. But either way you look at it, Asian Americans are the fastest Jewish racial group, right? With 24 million in the United States. And this is the thing that just came out a year ago that still, you need to remember. It's not heart disease that we die of, that Asians die of. In men and women, it's cancer. It's not heart disease as the #1 killer. In white people, in black people, in Latin, it is heart disease. In Asians, across the board, by far, it's cancer. But you're all worried, don't get me wrong, you should be worried about your blood pressure, stroke risk, whatever, diabetes, right? Especially, you know, in the Filipino population, you're always worried about diabetes, but I see a ton of Filipino people with lung cancer too, but they're always thinking, they're going to die of diabetes. But in reality, all of that is way second to none. They're not dying of heart disease. Yes, you got to take care of your heart, but Asians get more lung cancer and cancer in general. Okay, so anyways, but why do we not think of us Asians as, for you hardcore postdocs out there, or epidemiologists, or maybe not even that, social scientists, if you guys have, has anybody ever heard of the model minority myth? Okay, good. Okay, so this is the way I portray it. I'm very simplistic, I'm a surgeon, right? I just see something and I cut it out, right? It's just, I'm not as intellectual as all you out there, but the model minority myth is basically like, all Asians look like us, pretty much. We do well, we drive a Honda, or maybe I drive a BMW. They all think we do that. They all think we speak pretty good English. They assume we're all very well educated, that we all come to these type of events, all that. So we don't get sick. And we're well, and we're healthy, and we go to the doctor all the time. We know exactly who our doctors are, right? And we know exactly what our health insurance is, right? Yeah, so, all of that, right? That's not true, right? But that's what's assumed. So people don't think of us as disparities. They don't think of us as a disparate population. They think we're just like white people, that we get the same privileges as white people, but we don't. We have we're totally different, right? But we're not treated like that. We're treated as a healthy group. So Asians don't count. We don't need to study cancer in Asians because they don't get cancer. Well, we all die of lung cancer, or not lung, just any cancer. Excuse me, getting ahead of myself. And what if I told you 0.17%, you guys are smart people, 0.17% of all the NIH funding, all the big time funding for Asian American research. I am totally into African American, black versus white. I understand a lot of those prejudices and discriminations, although as you know, there was a lot of the Chinese Exclusion Act, Japanese internment, my grandparents were interned. We have those issues too. We all just need to come together about that, but there's a lot of black versus white, or even now Latin versus white, right? They forget about Asian versus white when you study stuff, right? That's the problem. That's what I do. I do Asian American research, and it's not easy. They don't consider us a minority. We're totally a minority. I mean, come on, right? And you guys know that, but NIH doesn't realize that. These are all up to date, right? I do not just rehash my slides every week. What about, I want you guys to really think about this when I'm going to show a slide about a clinical trial that you can go on. It's very easy. It's just a survey that you can sign up for. But the issue is, this is not all the United States government fault. Clinical trials, Asians only represent 2%. It's mostly white, then Hispanic, then black. Asians are the last. And we know that based on our culture, based on a lot of different things, why we are, but it's also, so it's not always the government not picking Asians. It's Asians never want to do this. Or, you know, there's other reasons that I won't go into, but if we can't study the clinical trials, or if all the studies are on white people, or white and black, how do we know how you're going to react to a drug, or react to a surgery, if you're not even included in that? But that's all the data. The way I treat you is based on what we have on the data, what the science shows. But none of the Asians are never included in that. And so when people talk about stage 4 lung cancer, and they say, well, you can't get surgery because those patients don't do well in trials, that's true, but none of them were Asian females, right? The Asian females that do well, that get surgery with stage 4 do very well, right? And again, there's no studies for that, but if you do this work and you do this long enough, you know that you can't necessarily go by the studies, but how many Asians know to look at that? So again, I went off on that a little more than I should have, but so Susan should go, our problems never make the headlines, right? We don't speak out. We're just quiet, we're super nice, and then we're all gonna go home and never talk about this again afterwards, right? Nobody's gonna go out and post on Instagram or Twitter. I can't even find you guys on Instagram and Twitter, right? I just found Sky, it was impossible, right? She had to give it to me, right? And how many people are following me? Nobody, right? You guys need to get out there and get this awareness out. Not just me, but I'll be vocal for you, okay? All right, so yeah, Andrew.
Asian group have our own social media platform. You need to get on that.
Yes, and you can see I'm a little whitewashed myself. I'm 4th generation, right? So I don't even speak Japanese anymore, and that's partly the Japanese culture. We acclimatize. We acclimatize with the Caucasian, with all that population. Whereas China, Vietnam, maybe, but not as much, right? It's keep the language, keep the culture, keep the. I don't do any of that. We didn't do that as well. So that's why you're right. I'm not aware of that. I know it's out there, but I can't relate as much. And you guys may not even relate to me. Like when I do these little sessions in Chinatown in Oakland, and Angie does this. Angie gets way more feedback about lung cancer and stuff when she goes to the street fest in Oakland than I do. They look at me like I'm a foreigner, even though I'm telling them about lung cancer screening. But they go to Angie and they go to Tom because they can relate to them because of the language issues. They look at me like this is some, young white kid, even though I'm not. So I've learned that. So I know I can't. It's hard for me to relate to everybody, and I'm not on those chats. It's like I just don't understand the language, right? It looks very foreign to me. But you all here can help me and say, and post it, or send that and say, and that's what Angie does for us. That's why we're here, because Angie was able to put this together with everybody. So I appreciate that. So Asians, again, fastest racial growing group, fastest racial group in the United States. But the only reason I bring this up is, it's not California where we're growing. Right? It's not New York and all those places, or it's South Dakota, North Dakota. So we just gotta remember, those are the places that are actually more Asians are going to. So it's not just California, Seattle, and New York, and Colorado, where Asians are. That's where that's my stereotype, right? That's where I assume all the Asians are. I don't think there's any Asians in New Mexico, or where else is on here? Nebraska. Turns out there actually is. In Iowa there is too. I know because I have surgery residents that come from all these different places at med school. I'm like, there's a lot of Asian people there. But, we never think of it that way. So either way, we're growing, and we're out there. But our voices need to be heard, right? I don't even know an Asian person in Nebraska. We should find that out. But they need to be out there doing this. We know about Asians in California because there's more of us and we're more vocal, because we're more liberal, because we're not going to get, people aren't going to, well, as we know, 38% of us are going to get COVID-19 Asian hate. But you can imagine Nebraska, I don't know, right? I'm just speaking, but if Nebraska, me speaking out in Nebraska right now, I don't know. I'd be scared. I'm scared to go there. I won't go to Nebraska, although it's probably fine. So here I feel comfortable, right? Because we're more liberal. So maybe that's part of the issue, but we have to think about everybody, and I have to think about everybody. That's why I show this slide. Think about the people in Nebraska that are the women with lung cancer, or women that have lung cancer right now that don't know it that are in Nebraska. There's no way there's an Asian American BACCS there right now, right? There's just, so you can imagine all the underreported cases that we don't know about. All right, so we know we're extremely diverse. Just by looking around and talking to you all you have to know here, blue, green, orange, whatever, is that there's a big mix of us, right? Some of us were born here, some of us are not born here, some of us moved back and forth, and that's a difference based on all the different race ethnicities, right? Whether you're Burmese, Pakistani, everything, Chinese, Vietnamese, Japanese, everything. So there's a big mix of us. So that's kind of when we talk about all Asians, it's great, it sucks a little bit that we group all of us Asians together, but look, we're even in this room, the BACCS, we're different, right? We're differently made up of things, and so that's what makes it difficult to study Asians. It's just to know that we're so diverse, just in alone, although a lot of people pigeonhole us that we're all the same, that we're just all Asians, right? We're all the same, and we all know the same things, which is not true. So this is what I think is interesting. So if I asked you guys, and Angie knows I'm stealing quotes from Vu, our elevated leverage leader. So who has the highest income? But these are my slides though, actually. But yes, who has the highest income out of all the different race ethnicities? White, black, Latin, Asian. What's that? Asians do. Asians do. So Asians, we make more than white people overall, right? If you look at overall median income, it's not bad, 75,000, right? And look at India makes the most out of everybody, right? South Asian, 100,000. But look at Burmese, right? 35,000. So, and I'm not going to go into the reasons, but part of the issue is that, again, that's the model minority, that we all do well, that we all have homes, that we all drive Teslas, that we all work for Google, right? Or our parents are doctors or lawyers. We know that's not true, right? But that's what everybody assumes. And either way you look at it, we have the largest income spread, right? So somebody from Burmese, Asian, or Hmong, or living in Modesto may not be the same as some of us Asians that live in Mountain View. We know that's not the same. But everybody just groups us all the same, that we all do very well in healthcare, that we all, do really well in math. So this is the thing that really surprised me when I just kind of started researching Asian American research more. Remember, I wasn't always an Asian American researcher kind of into that stuff. It was more when I started getting patients that were all Asian. I was like, what's going on? Because nobody was talking about it. Even though in 2007 I was here at Stanford, but nobody was talking about Asians with lung cancer. Even though there was a oncologist here, Heather Wakely, that was looking at that. But I didn't know about it, right? And so we need to get that voice out. But Asians make up, now again, East Asian and South Asian, we make up the biggest population, more than white people. 33% of us are Asian Americans in the Bay Area. We have the biggest population, so why do we feel like the minority? We should feel like the majority, because we are. So there's got to be an issue with that, and I'm not going to get into the social sciences, that's not me, but just know that we have plenty of us here to make a voice, to start our own study. We should be able to do everything on our own. But the other thing, the red line is actually a bad sign. It means that you're higher under the poverty line the higher you are, and that's Asians. So not only do we have more people, we actually have more people in San Francisco that are actually the most underserved, and I can't speak right now, but poor, right? Compared to black, Latin, everything. But you don't necessarily think that. You think, oh no, we don't have that. And so people disregard it. They just assume that Asians are all doing very well and have health insurance and all that. But we know that that's not true. Okay, so now let's focus a little bit. Okay, we're doing okay. You guys okay on that? Okay. So this is where I think this will start to bring it home now a little bit more. So Asians continue to be diagnosed more with stage 4 lung cancer. Even despite lung cancer screening. So lung cancer screening happened in 2014. You have to be 50 to 80, current smoker, or you quit within the last 15 years, and you have to have had at least a 20-pack year smoking history. That started in 2014, covered by everything, insurance, Medicaid, Medi-Cal. So that's the graph on the left. Asians were still diagnosed more with stage 4 regardless of lung cancer screening. We're still right up here, yellow, stage 4. We're still more diagnosed with stage 4. But what about white people? Caucasians switched after lung cancer screening because they're the ones always getting lung cancer screening, right? They're actually the ones getting it all. It's helping them though. They're going from here, now they're more diagnosed with stage 1 than stage 4. So they're benefiting. Us Asians aren't. So how do we change that? And remember, we know plenty of family members, and this is cultural patternism, but yes, our men, our husband, that are smokers, they qualify for lung cancer screening, but don't want to know and don't go. I have a research study on that right now. Most of them, even though they qualify, and it's free, and I'll drive them there. We have navigators drive, they won't go, they don't want to know, right? So you can see why we're doing poorly, and we need to change that. But that's a different talk. That's for our smoking men population. So this is my patient Yoko. So again, Japanese, this is the tumor that I took out of her. She was stage 4. We did surgery on her. Everybody said not to, that she's gonna die, that you can't do surgery for stage 4. Well, yeah, you can. And this is how she looks. This is after surgery, but even before surgery, she looked even worse. You can tolerate, Asian women can tolerate surgery better. You're actually healthier, believe it or not, and there's more to you than you think, but most Asian American women are very anxious about things. Asian or Asian American, however you want to look at it. And so you may not come to the forefront. And even if I do push you towards it, which I have plenty of patients, they back away from it. I'm still learning this nuance. I maybe come off too aggressive. I'm just like, let me help you. And they go, no, I don't want to get treatment. I'm fine. Let me keep going on the therapy. And I'm working on that. Maybe you guys can give me feedback on that, my strategies. Get second opinions. So there's the Asian, let me do stereotypes, right? There's the Asians that have their kids that all went to Stanford or they're all doctors and they get 5 referrals, outside opinions, second opinions from everybody that are annoying, right? Then they don't know what to do. And then there's the other Asians that don't know to get an opinion or limited English proficiency, don't get anything at all. Somewhere in between. My recommendation is 2 to 3. You get more than 2 to 3 medical opinions on something, that's plenty. Doesn't matter where, UCSF, MD Anderson, wherever, you get more than that, it's gonna get too complicated and then you're not gonna know what to do. But I do recommend second opinions, always ask. Always ask, especially for lung cancer now. Ask for another opinion. I do agree with that. Or that's why I talk about that, but a lot of Asians don't necessarily know to ask that. I just bring the slide up because even if your friends or family have stage 4, that doesn't mean there's no treatment for you left. That's what a lot of Asians think. Your Asian female friends that have stage 4, they think, well, once that drug runs out, which that drug will eventually, right now, every drug you'll eventually get resistant to. Whether it's year 2, 3, 4, 5, maybe sometimes 10, you'll eventually become resistant. So a lot of people give up after that. I'm here to tell you, Yoko will tell you, she's not here, she's in Concord, but you can get other things. Surgery can actually help for you. Okay, and in certain circumstances, I'm not saying go and tell everybody you need surgery, but to get a second opinion. So how do we increase the awareness? Be proactive about your health, okay? We're gonna go into that a little again, but be proactive about your health. If you have a family member that keeps on coughing, if your grandma keeps on coughing, don't keep on giving her Cepacol or throat lozenges or Ricola. They need to come into a doctor. If the doctor doesn't give you an imaging test, you need to push that as the daughter, as the son, as the sister. You need to push for an imaging test. The study that I'm going to show you in a second is our UCSF KP fan study. It's called the Female Asian Never Smoker Study. You can sign up for that. We're trying to figure out why Asian women are getting it. You don't have to have lung cancer to have it. Certainly, one arm is lung cancer women. The other arm is women, Asian women in general. So you can sign up for that now. And then we got to focus on high-risk populations. Limited English proficiency, right? That's the group that we need to catch a little bit more that don't understand exactly or aren't on the mainstream media or on Chinese media where they're not maybe talking about this as much. Asian families, and I want to keep on bringing the home family history. If you have a family history of lung cancer, you are at high risk, okay? Nobody's going to tell you that, but I'm going to tell you bluntly. You are at high risk, and that is a risk factor for developing lung cancer, not only just being Asian women as well. All right, so let's go specifically Chinese American women. Lung cancer, this is fact. This is not me just like boring you. Lung cancer is the leading cause of cancer death in Chinese American women and Chinese men. That's the highlighted. It's not breast cancer. It's more than double breast cancer. Chinese women, I told you that Chinese women and Asians overall, number one cause of death is cancer, and then the number one cause of that is lung cancer. So that's the number one cause of death. And I just told you that 95%, or in some countries, 95% of the lung cancer are in women that don't smoke, okay? So this is clearly an issue, but why are we not studying this more? Asians are less likely to be diagnosed early, and the incidence is highest in the West Coast. So we need to activate. We need to talk more about this because this is where it's all happening. It may be happening in Nebraska, but again, I don't know many Asians in Nebraska. There's still more Asians in San Francisco than Nebraska. So we need to talk about it here, and we need to get you guys all signed up on studies. We need to promote this. We need to tell our parents to come in to get a screening study. So these are my patients. Christy, obviously you know in the middle, she passed. Susan is still alive, she's doing well. These are all Asian American young non-smokers. Phoong, Vietnamese, is doing well as well because they were caught early. And they came in. But they were also doctors too. So they knew to come in, right? So this is more on the rarity side. But we need more women to understand that regardless if you don't know but they didn't actually know about the increased risk of Asian women with lung cancer. The amount of Asian women that get lung cancer, I just told you 57, so 60% of Asian women in the United States that get lung cancer are not smokers, okay? And the majority versus the 13% of white women are non-smokers. So all that tells you is the women that are Asian that get diagnosed with lung cancer are most of the time non-smokers. So we can't think, well, you're not gonna get lung cancer because you don't smoke. That's all you have to think about with this slide. So that's Susan, that's my patient. We talked about the awareness a little bit, what to do, but this is, I'm not trying to promote myself, okay, but this is a video that Kaiser is super cheap about this stuff. They paid a lot of money for me to do this video, and yet, they're bad at selling things or propagating because I don't think anybody's ever really seen this. Even though, I'm kidding, but anyways, you guys get to see it though. And this is what you need to do if you're an Asian woman and you're worried about things, and what can you do?
Hi, my name is Jeff Velotta, and I'm a thoracic surgeon at Kaiser Oakland Medical Center. I'm also a lung cancer researcher in Asian Americans, and today we're going to talk about lung cancer in non-smoking Asian Americans, an unknown, unmet health crisis. We do see a slight rise, actually 2% per year, of our non-smokers, both Asian male and females, getting cancer. The main thing that I want to let everyone know is if you're having respiratory symptoms, persistent cough or shortness of breath or even a little bit of chest pain and it's ongoing, specifically longer than 4 weeks, and it's not getting better, please see somebody. Talk to your family, see your doctor, get checked out for a potential X-ray or CT scan.
Okay, that was the key. It's an imaging test, right? You have to get the imaging test. If you don't get the imaging test, I can't catch it. So no getting Zyrtec, no getting albuterol, that's fine after a week or two. The issue with Asian women is, if you look back at all the charts all the women that I operate on, they've come back multiple times when they were never given their X-ray or their CT scan. So you have to get the imaging. You have to be proactive about your health. That means you have to tell your family member that may not speak English or doesn't want to come in or doesn't have the means to, because right, we're not all able to come to Stanford here, right, to come in. And your doctor, that's not a screening test. Your doctor can cover that. They cover that because you have symptoms. So then it becomes a CT scan. It's not a screening CT scan, but it's still a CT scan. This is the same stinking CT scan that you get, right? That's what you need to get. Okay, so let's talk about the data. I just told you lack of awareness. I just told you what to do, right? If you have symptoms and it's longer than 4 weeks and it's not getting better, you need to go and see your doctor and get an imaging test. At a minimum, chest X-ray, ideally a CT scan, okay? So now I just said lack of research. Well, we try to change this. This is Christy again. This is the research that we all published. So I'm going to show you all data from Northern California. This relates to you people out here. All data in Northern California. These are actually all Kaiser members, so maybe not technically all of you, but your family and friends. Patients with lung cancer who do not smoke are usually female, Asian, speak an Asian language, so Cantonese or Mandarin, have adenocarcinoma, and are more likely to be diagnosed with stage 4. So I just proved it to you. It's the same as nationally. Here, we haven't made a dent in it, even though we talk about this all the time, okay? So it's there. And then this is the thing that scared everybody, which is why the press went off, right? The colon cancer thing is a big deal right now, but this is the thing that showed up last year. So we published this that in our population, per year, lung cancer is increasing 2% per year in Asian women. Okay? Every other race, ethnicity, male, female, lung cancer in general, it's decreasing. Asian non-smoker up there, it's increasing 2% per year in our population. So why? People want to know why, right? Well, we think it's this thing. So whenever you hear biomarkers, that's the new thing. So if you get lung cancer, you need to get your biomarkers tested. And a lot of Asians don't know what biomarkers are. They're not necessarily, we used to call them genetic mutations, but it's not something that needs to be passed down. It's something in your tumor, as you as an Asian female, that's different than somebody, say, that's a smoking white male. It's different, and it's called EGFR. 50 to 60% of my patients will have EGFR. The reason why that's important is because there's targeted treatment, a pill therapy, that gives you and combats not just any lung cancer, your exact genetic type of lung cancer. That's why people with stage 4 lung cancer, Asian smoking, non-smoking women are living longer. The issue is what happens when they mutate, so we have to do better and get more drugs. But either way, it's the biomarkers in your tumor, in your lung cancer, in Asian women tumor, that are causing the lung cancer. The question that you all have is, well, what's causing the genetic or the biomarker mutation? Is it smoking? It's not smoking, right? Because we said non-smokers. Is it pollution, cooking oil, charcoal? So in China, we know that those are high risk factors. There are cities and villages in China where 30% of the women all have lung cancer. But they were living in rural countries or rural areas where they had no ventilation. The cooking oil index was very high, which they can actually measure in China, and high levels of radon, and high levels of just toxic coal, the charcoal that they're cooking with, right? That's what people think it's all from. That's not relatable. That's in small southern rural towns and northern of China. Why are we seeing that here? I showed you all data from here. Everybody just assumes it's all from that other stuff. You don't all cook under a wok all day, right? I don't think so. That's a stereotype. You probably don't, right? You use modern stoves, whatever. Come on. So that's not the reason why. So we got to study it more. But everybody just assumes it's the cooking oil. Oh, it's the secondhand smoke. Are you guys all around smokers? No. Come on, right? Susan and Fung and Christy weren't around smoke at all, and they get it. So it's hogwash. But that's why a lot of people stop with the research, because they're like, that's why, or that's why. I was like, no, you have to study it further. But again, that takes research, that takes money, that takes activism to say it's not just secondhand smoke. So we looked at our study, we looked at our patients, right? 62% of our Asian women had EGFR. That's a lot. So even though it's bad that you got it, or not necessarily bad, but unlikely, I don't know the right term right now, but you got it, you weren't a smoker, you're Asian, right? You're bummed, right? Well, don't be, because there's a 62% chance that you'll have EGFR. Whether you're early or late, you're gonna have a way better survival. So there's always a good and a bad, but at the same time, think of it, I'm trying to give you the good parts, that Asians do much better even in our system as well, okay? So there's better treatments, and because of the EGFR mutations. So here's a study that I want you guys all to join and look at. UCSF runs it along with us, Stanford as well, Heather Wakely, UC Davis. This is called the Female Asian Never Smoker Study. All you have to do, we send it to you online in Chinese, Japanese, whatever, okay? It's an online 30-minute survey. You talk to me where you were born, what type of food you eat, what type of roof you live in, where do you live, are you from Mountain View, are you living in Modesto? All that takes 30 minutes, you get a $50 gift card, $50 to $75 gift card. They send you a saliva cup, you spit in the saliva, easy. It's easy, right? And then you send it back in. You do not have to come in. You do not have to come in. And then, if you're the lung cancer group and you're diagnosed with lung cancer, you have a family member diagnosed with lung cancer, you will give your genetic profiling up or your biomarker profiling up, because you've already been diagnosed. So whatever hospital you're at in California, we will get that for you. You don't have to go in and do anything. If you're here and you don't have lung cancer and you're age 21 to 90, which is everybody here, right? I don't think anybody's over 90, right? And you don't have lung cancer, you could be the control. I gave you up-to-date numbers. We only have 323. So when do you think we started this study? Does it be a guess? I don't know. What's that? 2010. 21?
No, 10.
2010? Oh, interesting. No, that's actually what you think of. Like that would be forever though, because we're just That's what but you're right. That's right what I'm getting at is we started this in 2000, over 3.5 years ago, and we can't get 600 people, Asian women, non-smokers to do this. Right? You guys should all go home and do this, right? And I know you want to, but you're gonna go home, you're gonna go to your kids, you're gonna go to your lives, and you're gonna go back to working, you're gonna I gotta work on Monday, and whatever, right? And look at the lung cancer cases. So you guys are all asking me, what's causing this? Well, we're trying to find out. This is the one study that's gonna show that because we're gonna correlate all those different risk factors that you're talking about and match it, even by race ethnicity. So we have a certain amount of Thai, we have a certain amount of Bangladesh, we have all that, but we can't get the patients. And the reason why that is because, and you guys all know this because I know when I call my own patients, they don't, oh, my patients, they answer because I've had surgery, so they want to know from me, right? But you get another call from Kaiser, you're like, I don't know, I don't really, want to, especially if your English isn't great, right? And we're calling, it's a 42% refusal rate. So even though I just came up to you and said all this important stuff and whatever, 42% of the time we ask people to do it, they say no. And what's the main cause in Asians? It's actually passive refusal. Half of those group, passive. Do you guys know what passive refusal is? We call you and you don't answer. Or you just say, you think it's spam. Or you think you're worried that they're gonna get your number and like find out where you live and come rob you or whatever. All that stuff, right? You never answer the phone. My Asian patients are the worst, right? They never, the ones after surgery answer because they're like, I had surgery, they wanna hear from me, right? But the ones before, you're trying to get a hold of, even with lung nodules, very hard to get a hold of. That's what we're having issues with the FAN study. You guys may say you want to do it. You may even sign up with me right here, but then when I call you, you're not going to answer next week, right? It's totally true. I'm actually one of the FAN's recruiters. So this is how much I care. I am the one going to recruit you. I'm actually calling them because we thought that doctors calling, we would do better because Asian deference, right? Oh, the doctor, whatever. I introduce myself all the time. It doesn't matter. It doesn't work. I've been doing this for 2 years. This is where we're at. So we know our population. How do we change that? You can tell me, you can tell your friends, or whatever. That's what this awareness thing is, right? I'm out here, yep, I'll go. You good? So this is the QR code. This is the website. You go to, you click on it, and you can sign up, okay? That's my email, but I've already given you my Twitter thing. You guys, will have this, but that's how you do it. Okay, and then lastly, this is what you guys really want to know, right? Screening study for Asian women non-smokers. Okay, so the two on the far right, NLST and Nelson, are in, that's why we have lung cancer screening for 50 to 80-year-old smokers, because we found 1% of everybody that was screened caught lung cancer, and then there was a 20% reduction in death. That's why. But you have to be 50 to 70 or 50 to 80, right, smokers. But we do have, just came out, we do have 2 studies in Asian non-smoking women. Talent is in Taiwan. They studied 12,000, they actually did men too. But for this purpose, we're going to talk about Asian non-smoking women. And you had to have one risk factor. So what are the risk factors? Family history is a risk factor. Cooking index. So if you're stuck in a walk and you don't have a vent, and you live in, I don't know China as well, but you don't have good ventilation, they can measure that there, and that's a risk factor. A history of TB. I bet you didn't know history of TB is a risk factor for lung cancer. And a lot of people from China have TB, or old TB, but it is. And a history of COPD, which is kind of like the emphysema, which a lot of Asians actually do have, believe it or not. If you had that, you were screened. They caught more than double the amount of lung cancer in smokers. And then guess what the biggest risk factor was? You guys know what's the biggest risk factor? What goes up even higher than 2% to 4 to 5% is if you have a family history. And then guess what goes up even higher past 4 to 5%? If you have a family history on your mother's side, and it's your initial mother, and then multiple, your mother, your grandmother, everything, there's a really high chance, okay? But a lot of us don't know the history of them because maybe we didn't know them or whatnot, but that's why you need to find out, because those are the highest risk. And so we found that. So then you say, that's just Taiwan, right? Everybody's Taiwanese there, so that's not relevant to the United States. The other copycat, I'm just kidding, Elliot Chubb, they call the VAN study, the Female Asian Never Smoking Screening Study at NYU. They looked at 200 women, And they just looked, they didn't even look at a risk factor. They just looked if you're 40 to 74, Asian, non-smoking women that lived in right near NYU. They just took anybody off the street, Asian women, non-smokers. They found 3 out of 201, which is 1.5. That's high. Take 200 women off the street right now, take you, and maybe there may be one of you that they caught something, and they did catch lung cancer. We don't know, this just happened, so we don't know to follow them. They've all been treated, because I know the investigator of the study, they've all been treated, they all had surgery, and they all had EGFR, and they're all doing fine. But just imagine, if they caught that at stage 2, what happens if they wouldn't have had that? They would have been stage 4, and then we'd have to go on what we talked about, the targeted therapy, which without surgery. They had surgery and then targeted therapy. So, bottom line is, this is coming. This is what I want to do. This is the study that I have out right now, which is to do anybody, I go back and forth the age group, but whether you're 30, 40, 50, but probably 40 or over, it is a lot more rare to have lung cancer at 20, even in Asian women. We see it more commonly in 30 to 40, but really 40 to 50. So you have Asian female non-smoker, regardless, any Asian female, so South Asian, East Asian, and you have a family history. And I'm going to do it where it doesn't have to be your mom or your grandma, and it can even be on your dad's side. And anybody, family history of lung cancer, you're going to get screened. Yeah?
Does it have to be lung cancer or family history?
The family history one for this higher risk, right now, it's lung cancer. But, good question. Right now we're looking into if it matters, what about the other cancers?
Yeah.
Specifically breast cancer. And preliminarily, yes, breast cancer, we think, is a risk factor for Asian women that get lung cancer too. But again, that's not known yet. That's something we're looking at, and that's what I'm finding. So right now, it's family history of lung cancer. So if you have that, we get a CT scan on you. We screen you. And if we pick up 1.5, so out of 100 patients, we're going to do 100, 50 to 100. If we pick up 1 to 2 of those, that's all we need to show that it's relevant. Because I told you that these massive studies are the reason why we have lung cancer screening now in this country, because of these 2 studies, and they just found 1%. These were high-risk smokers. So if we can prove this, which is what Angie knows that I've been working on, and through whatever reason, through the different ways, through either modeling or whatnot, or just getting a CT scan and running that study, then we can convince people that your risk that Asian non-smoking women, age 40 and over, with a family history, should all get screened. I can't do just every Asian non-smoking woman right now, right? The United States is going to pay for that. The government's not going to pay for that. I don't have funding to pay for that unless one of you guys are wealthy and gives me $300,000. But even then, that's only going to get me 100 patients, right? So we don't have that. There's a lot of Asian women here. 33% of our Bay Area are all Asian, right? That's all I need. We show that, then, for example, Kaiser's not going to listen to this, but I'm going to get Kaiser we can institute that guideline, at least in the Kaiser system. Maybe it's not everybody. Maybe you're Sutter, maybe you're whatever. But at least we could start somewhere. We got to start somewhere, and I work at Kaiser. So that's what we're trying to do. So that's where we're headed. That's what you need. That's what we need to do. So hopefully that'll, light a fire. Take-home points, sorry to end. Lung cancer, #1 killer, right? Asian American women, it's not heart disease. You do not have to be a smoker, we all know that. Lung cancer in Asian women, non-smokers, it's increasing in incidence, real time, in the Northern California, in our population, and you're more likely to be diagnosed with stage 4, where it's spread everywhere. So how do we need to change that? How do we change that initially? Before the CT scan stuff, you have to be proactive. Usually, even on the early stage, and I'll bring patients next time if we ever do something. I have patients that it's like they all had something. It's very rare that they didn't have anything. They usually have a cough, a tickle, and they just thought it was allergies. They thought it was asthma and everything, and it's usually ongoing. So you got to get the imaging study when that happens. That's what I mean by proactive. If I don't have an imaging study, I have no idea if you have anything. Okay? Ideally, a CT scan, and they're low dose. I know that was going to be a question. They're low dose. We have low dose CT scans out. They're not going to give you radiation or extra cancer. Old school CTs, yes, but these are all low dose CT scans now. Chest X-ray will catch it 20% of the time. Majority of the time, it doesn't. But it's at least a minimum. If you have something really bad, we'll catch it on X-ray at least. And that's real easy. The doctors, it's super cheap. They'll get that pretty easily. So at a minimum, get that. But ideally, a CT scan. And it'll be a low dose CT scan. You ask for a low dose, non-contrast CT scan. Okay? That's how I'll know. family history of lung cancer. If you have family history of lung cancer, you're Asian female right now, I would tell you right now, if it was me, I'd get a lung cancer screening. I'd get a CT scan. You can't get a screening scan. I can't call it a screening scan, but I'd get a CT scan. You have a high chance, at least 1 to 4%. That's high enough for me. Again, it's not covered. So again, people get mad because they're gonna go to their doctor and they may say no, but this is just us in this small room telling you as what I think I'm an expert. I don't know, maybe just an expert here in Oakland, I don't know. But I think I'm a natural expert and that's what I'm recommending. So if I have family members like that, that's what I tell them to do, okay? It's the family history. So let your family and friends know. Navigators are how I'm using navigators that speak Mandarin and Cantonese. Because they don't want to hear me, right? I told you that the patients don't understand when I have a translator call in, even though I'm a doctor, it just doesn't come, we're not seeing eye to eye. So now I'm trying the navigator thing. So I have research funding to use navigators to call, and I also don't have time to talk to you for 30 minutes about doing this and this and that. They do though, because we're funded. That's what they're doing for the whole time. So that's what we're doing, navigators, promote research, promote the awareness. These are things that you can come out to. We're gonna talk more about lung cancer screening, but in the smoking Asian population, where I think I'm giving a talk, yeah, in Palo Alto, May 11th, and April 20th, you can come out to, where is that? San Jose. It's in Vietnamese, so, well, I guess it's probably not maybe a bit, but yeah. And then I'm giving an English one, but that's the one on classic lung cancer screening and smoking Asian males. That's another group we're trying to target, right? All of our husbands, our fathers that smoke like a chimney, that qualify, that don't come in. How do we tell them to come in? So that's what that seminar is about. And yeah, that's it. Thank you guys. Yep, here's the thing. Thank you.
Do you guys have any questions? No, not yet. Oh.
I have a cousin. Her mom died from lung cancer, and we know the reason her mom got lung cancer is because of the second-hand smoke. Because her dad is a heavy smoker. Should I recommend her to go and get the screening? But because she doesn't get the second-hand smoking as her mom did.
Right. So one of the things I like what you said, but one of the things that you said that we don't know if that's completely the case is you assumed, and something against you, if I'm hearing you correctly, you assumed that your family member who was a non-smoker Asian woman that got lung cancer, but you assumed it was because the secondhand smoke. That isn't necessarily, there's plenty of people that have secondhand smoke that not. So that's actually, so it doesn't matter about the secondhand smoke, it's just the family history that answers your question.
I have two questions. The first one is, I previously talked to my primary doctor about the best way to get screening for brain cancers, and he suggests that although in America screening cancer is probably suggested for ages like 50 something, and I'm in 30%. I'm in good shape, totally fine, and it doesn't suggest that. But if I insist to do one, he suggests to I make the phone call and claim that I'm Asian and I might have the potential to get certain cancers, and want to make this argument myself to do that. And I'm just wondering, from your perspective, what's the best way for Asians to get early cancer stage screening?
Right. To answer that first question, though, my question to you would be, do you have a family history of cancer or in the family, or is it just you being Asian male?
My mom's dad has the breast cancer.
Okay. It's not, yeah, it maybe, but that's the problem, is that they're gonna go, what are your risk factors? You're gonna say, well, I'm in my 30s, Asian male, that's not as strong, but that's not a strong enough risk factor where you'll have any doctor that'll give that to you, whether it's a screening test. But what you can do, okay, so what I do tell, this is cheating the system, but what I do say, it changes when you say you're having symptoms. So, but it also depends what you're looking for, right? If you're looking for a pan thing, a pan scan, like meaning knowing everybody, knowing everything, there is Grail and certain biotech companies are coming out with a blood test, a screening blood test, and they're looking at it with colon and lung. So they don't have one yet for all cancers, like kidney, everything, but they have colon and lung. That's the most accurate ones. That's coming to fruition. Right now, it's even out. It's on a clinical trial right now. We are testing people right now for blood, just on a regular screening thing, but in higher risk people, meaning people over your age, not your age, but 50 and over, and we're testing that. Right now, if you go to certain companies, they will, in studies, so we can talk about that, there are studies that you can go on where you can get that blood test and see. You just don't know how accurate it is yet because there's a bunch of tests out there. There's about 10 different companies right now that are promoting exactly what you're talking about. Do a blood test and tell me if you have lung or colon cancer, no matter what your risk factors are. So until that comes out, which is coming out, we're studying that now, actually. Until that comes out, your best bet for you specifically is the only way you're gonna really get it, if you stay at least in the States, you can get it if you go to Asia, but if you stay in the States is if you're having symptoms, a cough, and it's persistent, and you've already told them you've been on the cough drops, you've already been on the inhalers, you've been all that, they'll usually allow you to get at least an x-ray. But again, that's probably not gonna catch it. So I'm not saying you're not completely at risk, but you're very, very low risk. And so it's the symptoms that changes the doctor's itch. So because the reason why that's important, because the doctors, they will get rejected. So even though they want to give you a CT scan, right? They do the CT scan and they bill the insurance will reject it. So Stanford just paid for your CT scan and they're not gonna get any funding back or any reimbursement. So that's why they're gonna say no to you, right? But if they put on there, not a screening study for you, but cough, that's a diagnosis code. That gets billed by the physician to the insurance company and they go, cough, CT scan, x-ray, that makes sense. That's a standard procedure. Guess what? Then that's covered, then you can do that. But I'm not saying you need to actively lie. That's the problem. I'm not saying that, but that's what some people do to get through things. I'll be honest though, with you, I think you're very low risk.
Yeah, and also the other thing is, this is why we really need your voice when it comes to policy change and politics. Because in the United States, and especially California, our population is big, but we're still invisible. And to have insurance to cover it is really not easy. It's difficult, even to hospitals per se. So we really need your voice to your, if you have a chance to talk to any assembly member or your district, politicians, and bring this topic to them, especially those Asian Pacific Islander ones. Those are the ones pay special attention to our community. So to see if we can get some state level policy change, then when state of California requiring insurance to cover it, then the insurance companies will follow. But to wait and see for those big money for-profit insurance companies to take initiative to our population,
That'll never happen.
Yeah, that will never happen.
Yeah.
Nearly impossible. It just it's like not in
my
our
life.
profit structure.
Yeah.
So that's why we need your voice. Come out to our community and make your voice heard. Thank you. Second question.
My second question is, what's the ideal frequency for each age group to do the screening? Like, I want to be healthy, but I cannot do screening like every half year, right? So in 30s, maybe 5 years or something. But
that's wrong. We don't know, right? Because it's recommended to not do that. It's recommended that it's not helpful to your at least 50 for lung. For breast, 40, unless you have high risk features, you go 30 to 35. Cervical, as you guys know, is in the 20s. Colon cancer is now 45. Used to be 50, now it's 45. So you're getting there to get to those things, but your age group, there's just not a high enough risk. It's just so low. Even in Asian, it's really low. So I can't really guide you on that. But I will tell you, once you do get to a higher risk, whether family history or you get slightly older, we recommend it's yearly. It's yearly. So for colon, when you poop on the stick or it's every year for that, or colonoscopy every 5 to 10 years, depending on what you do. But if you do the poop on a stick, it's every year. Mammograms, we know it's every year. For lung specifically, it's every year. So ideally, it'd be every year. But again, I'm not your doctor, but you'd be pretty low risk if what you just described to me. You'd be a little more risk, but I wouldn't be as too concerned.
Hopefully, thanks.
Hi, thank you. So I have a question. Well, first of all, to echo what y'all guys were saying, there's a lot of fundings for these clinical trials. They're not really focusing on Asian Americans, like you say in the slides. And some of the features I used to research in this field. For example, for female breast self-examination, breast tissues of generally white women may not be the same as Asian women. So the self-examination may detect a certain group, for example, white individuals' breast tissue, but not Asian ones.
Yeah.
So we really need to have the voices heard to include Asian American subjects into these clinical studies. Therefore, funding is really important. I re-echo that perspective from the organizer. My question for you, doctor, is there are a lot of cancers, there are really no symptoms. You mentioned coughing, pain, but for those cancers where really they're asymptomatic, do we need to wait until we're symptomatic? That would be too late for stage 3 or 4. Things like pancreatic cancer, you can die without with very little pain to get to stage 4.
Correct.
So what would you recommend in the case where we're aware that we want to have screening for these cancers, but we don't have symptoms? Do we just need to convince our primary care doctors? Because our PCPs, they're not even willing to go for these screening. Like you're saying, insurance won't pay for it. Right. So are there other alternatives where maybe you can pay for these type of examinations, so screening outside of the insurance scheme, if you have the money to do that? Or there are other ways for us to reach these screening approaches for these cancers?
Yeah, so great question. So it depends a little bit, honestly, male, female. Obviously you're male, but on females, they're always going to have a slightly higher risk for all the cancers that we're talking about. So one of the things you can do is, depending on what insurance you have. So, for example, our Kaiser system. If you have Kaiser, for example, Kaiser, we just bill ourselves. So it's actually a little more doable, because when I submit something, I'm not supposed to say this, but when I submit something, right, it doesn't go question. That's the benefit of our system, because it's me billing myself. And if I approve it, it doesn't go to a higher up or another authority. So say somebody came in right now to me and is a female Asian non-smoker that's 50, but they have a mother that died of lung cancer, I would order that CT scan for them, and I wouldn't get questioned. Okay, that's that system. But you may say, well, that's not me or whatever, but Kaiser actually in Northern California, we own 45% of the insured population. So it's a good chance half you here, or 45% of you here have Kaiser. So I'm not saying to take advantage of that, because some of them, but you'll get a doctor to do that. That's one way, right? The other way is, you're right, you pay out of pocket. Sutter, all those big Mercy, they will allow you to pay out of pocket. It's about $2,000. But that's just for a CT scan. Now that's just gonna catch lung cancer. To get a PAN scan, that's $5,000. And again, that's not gonna catch all the cancers, as you know. It's not good for colon, it's not good for cervical, it's not even good for breast. So if I'm just talking to you lung, that you can pay out of pocket $1,000 to $2,000 for CT scans at actually any place, but Sutter, they specifically do that. And then the other technique is what a lot of my Asian patients do, actually, is they go routinely back to China, Taiwan, and Korea. So it is all covered. So that's what I recommend, because they will not second guess at all. They'll order the test, it'll be all covered. If you find something, guess where they come? No offense to the other countries, because I'm Asian, they come back to the States to get their treatment here, right? You get the screening there, and you come back here. And then lastly, the blood test. The blood test is coming. It'll be ready in about anywhere from 2 to 3 years, because we're testing it now. We're trialing it now, the blood test, to see what, and we're already looking at that. Like, multiple companies are already doing that. I'm on a study for that. I just don't know the answer yet. I don't know what the answer is. We're testing everybody, but I don't know. So we're probably about 2 to 3, 4 years away from that as well. So that's going to be the real trick. But my recommendation to this group, especially if you have family there, is Asia. All my patients that have done it in Asia, they said it's so easy, blah, blah, blah. It's just the treatment, I wouldn't recommend necessarily going there unless it's very reputable. Because China, which I'm learning a lot about China surgeons and China treatment, it's very variable. It's not all like the same as as kind of the States. So to at least let your doctor here know. But that's what it's worked well.
Yeah, and also in China and Taiwan, they have those things called specialized for physical exam hospitals. They don't do anything at all. All they do is just physical exam. And you just need to pay out of pocket and then go to those hospitals, pretty low cost. Right. You make US dollars. And like you can get it screened. And low dose CT is not dangerous to as those myths per se to us. And I think especially in Taiwan, I heard there are those special physical exam tours to Taiwan. Like people are organizing and having a lot of Asian Americans especially visiting Taiwan. So that's what I learned last week while I was in Taiwan.
That's true, yeah. It's called medical tourism, and I was at the healthcare and business school, at Berkeley, and there are actually startup companies that do that. They bring a bunch of Asian American women usually over, and they get all that stuff done there. It's like funded. It's like a whole startup company. So you're right. It's a real deal.
Yeah, and it's not easy to make an appointment. You have to, at least that hospital I was looking at, you have to make an appointment at least 3 months ahead because of how popular it is. Because in America, the healthcare system is not really very friendly to Asian Pacific Islander population because of all the model minority myths. I can tell you a true story. After we've been doing this community workshops, right? So I become self-aware, and I was trying to figure out if there are any ways that I can do. So January this year, my annual physical exam was due, and my new primary physician, she's Asian as well, Asian American, I think Japanese descent, and I talked to her about the potential risks for non-smoking Asian population, and her feedback was, what are you talking about? Ain't you very paranoid? So there are a lot of physicians and nurses that are not aware, so it's really just unfortunately about us to take the initiative, and not only just us, if you're, I can see from today's audience, we're relatively young, so also for our aunties and, grandma and a mom, especially in Asian culture, women make the primary financial decisions in the household, right? Tell our kids and our husbands what insurance they should buy. But when it comes to our own health, it seems like we don't really take good care of ourselves, either because of cultural stigma or being ashamed as we don't want to be a burden for the household. So I think, if you found out your mom or grandma or aunts having persistent coughs, we should really start that discussion with them. And also don't be afraid of cancer. If we can just view that as a chronic disease instead of we must die from that. It's world change is no longer like that anymore.
Yep.
So I just wanted to just mention the Asian part. I was actually in Asia in November because I took my parents back for some family issues, and we went through the hospital processes. We went through the physical examination. Now my question is, after we've gotten the results back, the scans, the ultrasounds, blood tests, right? Yeah. There are issues noticed by the Chinese doctors, right? But my American PCPs, they're not able to take those results. For example, you can say we do the diagnostic, the screening over in Asia, whether it's Taiwan or it's China, yet when we come back here for treatment, potential treatment, for example, we would have to get our PCP on board with that particular symptom. So in other words, he or she would have to redo the test. They're not going to take the Chinese ones on its face. But the PCP is not willing to do that. So
but that's okay though. No, I mean, I'm happy to help you personally because that's okay though. But no, the fact you have the report, because I've done this. I've had this patients come to me with this. They have the report. A lot of times, that's fine. But you can translate. It can be translated over and whatnot. And as long as you have that finding on it from there, yes, they may repeat the CT scan or whatever to have the one here if you can't get the disc over because wherever hospital was at. That's fine, but they are warranted, they're by law, by medical ethics, to still order and follow that because you caught it. That's the difference. If they just initiate that here and we don't have any, you have no symptoms and nothing, that's where you get caught. But if you have that, they have to, guaranteed. I've never met a doctor that will not do it if you have in writing, not the film, but just, hey, look, I have a spot on my liver, this is it. And then they will then, Kaiser or wherever, Sutter, Stanford, they will then order the liver ultrasound here, yes, to confirm that, and then they'll give you the treatment. And so it'll be covered for insurance and all that. The key is you need to get that first test there, and they will definitely, there will be no issue with that. Yes, they'll still order the one here, often to get our study here to get in the system, but at least now it's indicated, and you're not going to be charged for another CT scan or liver ultrasound.
So we should translate that report into English.
100%. Yes. And China will do that because I have plenty from China. I have a lot of my patients with small operations. It would be no problem.
Yeah, if you get on those, tours,
like, yeah, that you should definitely do. And then, you can email me if there's an issue. I can talk to that. That is, I've never had that issue. I've never heard of a doctor having that issue. Not just me because I'm proactive. It's any doctor because you have it. Hey, this is me. I have a liver spot or I have a thyroid nodule. This is my report, and then they'll have to order that here, and it's indication thyroid nodule because that's what you have.
Yeah, the other thing about Kaiser is we do have Chinese language module in Oakland, San Francisco, and also I think Santa Clara, right? Chinese language module.
Yep.
So we have primary doctors and surgeons. They are fluent in, like both Chinese Mandarin or Cantonese or English. So you can, search. MyDoctorOnline.org is a website set up by Kaiser. So you can search for all Kaiser physician, nurse profiles there, and then you can choose, you want a doctor who understands Chinese culture, indicated as multicultural physician practitioner. I think that conversation will be easier.
First, thanks, Dr. for the knowledge here. I just have a question about, earlier you mentioned, because this is a lung cancer in non-smoking Asian women, it's underdiagnosed. So I'm just curious, usually when they do get diagnosed, it's like late stage 4 or whatever. So what are their options? It sounds like you can still do surgery, even though many people will be too late for it. So what are their usual choices?
I think I know what you're talking about. So say you get it, so the next step is, say you catch it and maybe it's a little later, maybe stage 2, 3, or 4, because you're right, there's no screening study. What you next have to do, which I didn't go into, which maybe I should have, is and I did a little bit of the biomarker, the EGFR testing. So that's the key that a lot of Asians aren't getting, even though they should, is, I just told you, right, 62% are gonna have some type of, at least EGFR. And then now, there's even other ones that I didn't show because I didn't want to complicate things, other markers with new drugs that came out. 35 new drugs came out within the last 5 years for different molecular markers other than EGFR. So once you do get that, that's the key. Even if it's 2, 3, or 4, you need to get the biomarker testing. The biomarker testing, not all hospitals offer that, even though they should, because it's not mandated to them. It's not a requirement that they do that. So we looked at this study, and what do you think the percent of people with lung cancer? Because it's supposed to be everybody with lung cancer is supposed to get biomarker testing. And the whole population, white, Asian, white, you won't know the answer, but what did you guys guess that actually got biomarker testing? 38%. 38% get biomarker testing. And I just told you that could be life-saving. You're gonna live long, a lot longer with that. So that's why if you get the biomarker testing, and even if you catch it later stage, there are new clinical trials and new studies out that show you'll live a lot longer if you do a combination of surgery, either immunotherapy, and now the targeted therapy based on whatever the mutation that you have. And there's over 500 of them. It's a gene panel. But guess why a lot of hospitals don't want to do it? It costs $2,000. So they don't want to get it if, I don't want to say that, I shouldn't say that, but it's a money thing a little bit. And so you have to be, that's back to my thing. You remember you asked, what can you do? Proactive about your health. You learned about this, you know about this, you ask that, you tell your friend this, but how many of us Asians really know that, right? We all assume the model minority event, that we're all educated, that we know biomarkers, that you know about lung cancer in Asia. No, right? So I have plenty of Asian patients that are stage 1, 2, or 3 that I see afterwards later on that never got biomarker testing. And then we biomarker tested, guess what, they're EGFR. This is in our system.
Hi, Doctor. Thank you for sharing. This topic feels kind of personal to me because I have a close family member who also diagnosed it with lung cancer in 2014. So this year marked the 10th year for her to survive, and she was, I think, lung cancer stage 3 to 4. So this one is kind of like a question of what would be some of the journey of Asian female if they survive the 10th year, and what would be the trajectory after that? Because this is a psychological question to me, because I don't know how I treat her. She doesn't feel like a patient anymore, but she definitely has that cancer inside her.
Okay, so she's got some risk factors for recurring even later down the road. The good news is, yes, the longer you're alive, whether you even went through stage 3 or 4, even though it's later stage, the better chance, because it's probably the piano genotype. Okay, so with that being said, you reassure her and say that she's great, but what she needs to make sure of, I didn't talk about surveillance after you get lung cancer. What do? Asians, we see you get another one come up way after, even up to 10 to 20 years later. So what you need to tell her is that, yes, you're in remission, good, but you need to get a surveillance low-dose CT scan every year afterwards, because she's at higher risk of getting something even later on down the road. Just up to 2 years ago, in fact, I don't want to say this, but even at Kaiser right now, if you have stage 1 lung cancer, we stop screening you after 5 years, or stop surveying you after 5 years. That's because they don't know the data. I'm publishing the data now that Asians actually develop it later. So say you get one early, and you take it out, 5 years later goes by, you think you're in the clear, that's old news. That's not true. You'll usually get another thing down the road. And that's fine, if you catch it, you just chop it out again, or do something easy, because it's another small spot, right? So she needs to continually to get the CT scans to make sure, so she's not completely out of the wind, especially with being stage 3 or 4, which is the chance of her recurring is much higher in her lifetime than not recurring.
Doctor, I have 2 questions, 2 quick ones. The first one is, when we're talking about family history, how many generations are we talking about? If like my parents, if none of my parents or grandparents have lung cancer, but my cousin or my grandparents, brothers, sisters have it, like, is it also considered a part of family history? How many people in the family should I talk to understand their medical history?
Right, so it goes by risk. So the highest risk is mom's side. So your mom's side is always highest risk. So the highest risk for you would be your mom. Next highest risk would be your grandma. And then included, and then also on your, again, sister. A sister had it, that's all higher risk. And then the next highest risk is the father's side. Father, grandfather, grandmother on the father's side, all that. And then after that, it's uncle, aunt, and then cousins is last. And then second and third cousins is last, right? We don't have data to show that, but we do know the highest risk is your mom's side and immediate. So sister, mom, and then grandma, so the mom being the most, right? And then lastly, we do know the more family members that you have with lung cancer, the higher risk you have of potentially getting it. You may not get it right now if we scan you, right? But down the road. And then if that's the case, there is, I didn't talk about this, but there is now a policy. I don't know if I ever have a hospital, for example, Kaiser, we do have a policy now. We will get genetic testing, which is different than biomarker testing.
Okay, yeah, that's my second question.
You're not going to qualify though, because you look young. I'm sure you have to be you have to be closer to 50. And you have to have a family, yeah, you have to have one family history. Yeah, but pretty much they're not strict on it. So you can, but yeah, if it's a third cousin, that technically doesn't count, but within 2 generations, and just one. All you have to have is one. They will do that. Like breast, right? Breast, they do BRCA, and they do all that, right? Very really easily, right? But they just haven't caught on for lung. But finally they have, now they have, and you don't have to be a smoker. So if you have that, then you can get genetic testing. You won't get the CT scan yet, but at least you can get some type of genetic testing to see, if you do have EGFR. Because if you have EGFR, that doesn't mean you have lung cancer per se, because you don't know what the scan yet, but then they'll follow up with the CT scan afterwards to look.
What's your opinion about this commercial genetic test that you can get on the market, like 23andMe and kind?
That's the problem. They're not ready yet. They're not accurate enough yet. So I definitely don't recommend doing those kind of side things unless you're doing a clinical trial and it's free and you're willing to just whatever get your blood. That's fine, but you're not going to know the result right away, right? So you're just helping science to figure out how accurate it's going to be, because they're going to compare it to other things and then they'll put you through a scan, all that. So a clinical trial of doing that, if you're really concerned, I think is reasonable to do. But to go out and buy the one that you can that'll make commercially available, the problem is you don't know how to interpret that. Because all the tests have different accuracies and none of them are prime time enough where I recommend doing that. The only thing I recommend with getting those multi-gene, they're called multi-gene genetic tests for blood, and there's even a nasal one for a swab one for lung, but the blood one would be on a clinical trial. They do have those available.
Thank you very much.
A quick follow-up on that. So what if you tell your PCPs that you have family history of lung cancer? Does that count as a qualified?
Right. It doesn't. That's the problem. We know it does in Asia. In Asia, they will. But you're right. That's still not counted here. The 2 studies I showed were just clinical trial studies, and the one in the United States, the one in New York, is just a study. It's not even published yet. It was an abstract because I know the author, but we're enrolling people into a clinical study. So for example, you go in and you say, oh, my mom has lung cancer. Yes, you would be at higher risk. Based on the talent trial study, you'd be anywhere from 1 to 4% risk of having lung cancer, which is fairly high, right? If you're a non-smoker, young woman, right? So that's high. So in theory, we would say get a CT scan. But because that's none of that data, even though the talent study, meaning the one in Taiwan, is published, it was just published, that hasn't gone to what Angie's getting at, policy, which would be the insurance companies, Medicaid, Medi-Cal, Medicare, Kaiser, Sutter, Cigna, whatever, Dignity, none of them have adopted that. So until that's adopted, your doctor won't get it for you because they'll bill for it and they'll get rejected and the office will have to pay for that. However, the way you have to get around it is you say, you're right, this is where Angie's talking about. This is where it does make a difference a little bit. Although, as we know, not all of your Asian doctors even know about it, right? Her Japanese doctor didn't know about it or whatever, right? Because a lot of doctors don't know. I talk mostly to doctors about these things because they don't know about it. Angie knows. I literally do grand rounds at every single hospital, all 21 Kaiser hospitals. I'm almost finally done. I got 2 more to do of a talk similar to this, but more medical. And they're always like, what? I didn't know about this. So your doctors don't know. And these are doctors down here. I did San Jose, I got Santa Clara coming up. So with that being said, you get a culturally sensitive doctor and you say, hey, look, I think, no offense to him over there, it's a little overkill if you don't have a family history, you're male, you're 35, that's probably overkill. But I understand, right? But for you as an Asian female with a family history of lung cancer, if you did have family history of lung cancer, I know you don't, I'm just saying, I know, but if you do, then yes, the easiest way to do it is to talk to a culturally sensitive primary care physician, because it's going to be your primary care physician that's going to order it. And what they'll do to get around it, again, hopefully this is not all recorded, but to get around it is they'll put in the thing. So if you come to me, what I do is I put in cough, and I order the CT scan, right? Kaiser, it's easier to do it because we don't bill. We don't have a billing policy as long as we put down what the reason was. We put down cough because we're culturally sensitive, because we know that there's no screening test for you, and we know the literature, or we know that. But how many people really know that literature? That's even culture that are Asian. They don't know, right? So that's the problem. So you have to come to this, and you have to talk to people, and that's why nobody's getting these tests because. So I did it. So that's what you'd have to do. And just so not to freak you guys out, but out of the Kaiser patients that we have, so we have 4.5 million members in Northern California that are Kaiser members. Then I broke that down and looked at, again, this isn't published yet, I turned an abstract in to CHEST, it's like this major place. We looked at it, and believe it or not, there are 2,000 Asian women right now in the Kaiser system. Maybe it's one of you, I don't know, we don't know the names, but 2,000 Asian women that have a family history of lung cancer. So I already have my study. I only need 50 to show 50. Because everybody's always like, in Nebraska, you can't do this study. Even in New York, it's hard to do this study because everybody's got different insurance in New York. They don't have the patients. How are you going to find 50 women that are 40, 30s, or 40s with their mom with lung cancer? Well, I have 2,000 of them here. So we have the prime study to do it. But I'll tell you, even Kaiser doesn't want to do this study, right? So I have to get outside funding. So my plug to that is the people that are on board for that, and that's how I've gotten a lot of my funding, is pharmaceutical companies. Because they're all the drug companies, and specifically AstraZeneca, Bristol Myers Squibb, that's how I get a lot of my money, because I need to get money somewhere, right? It goes to research funding for this because they have the drugs that target all of the Asian women out there. Why all the Asian women that you know about that are alive so much longer is because of those drugs. They get caught in stage 4, but then the drugs keep them alive longer than if you don't have a target. And so they want you to get biomarker testing. They want me to get biomarker testing. They want me to find these cancers earlier because I'll treat them and then they'll go on a drug, right? So utilize that. Utilize that by saying, okay, well, give me the money to do the research, because none of you guys are inherently wealthy, right? I haven't met anybody inherently wealthy yet that's going to give me $1 million grant. Plus I'm at Kaiser, so you think I don't do research. But if I was at Stanford, maybe, but even at Stanford, I don't think they're giving anybody research money like that. Or at Harvard, maybe they would, but there's no Harvard docs really doing a lot of this stuff because none of them are like Asian, right? No, I'm just kidding. They are, but they don't. So that's how we're doing it, though. So that's how I'm going to get the funding, is through AstraZeneca. And then you may say, I know I'm going on forever, but you may say, well, AstraZeneca, of course they would fund this, right? Because they are the one that make what's called osimertinib or Tagrisso. That's the #1 drug that treats all these patients. They are going to open a study to screen women, non-smokers, with a family history, even without a family history, with a CT scan. But guess where they're doing it? Yeah, Korea and Toronto. High Asian populations. But guess where is it even a higher Asian population than Toronto? It's here, California. But they won't even give me the money to do it because they're going to test it out in Korea first. Nothing against Korea. Who cares about Korea? That's a Korean population. That's not going to help the United States. It's different. We're not all Korean women that are from Korea. So they don't understand that. So that's why I've been proving to that. But I'm in that loophole. Even AstraZeneca, who can make millions off of this finding that I'm going to pick 50 of you and find just one, they won't even give me $500,000 to do that. So I can't, what I would love to do is enroll all of you that would have that. I think having I don't want to just enroll every woman, but with the family history, I do feel strongly about that. Those women should be getting a CT scan. At least one initially to just see where you're at. To get funding to get every year like you're supposed to, if you're not in that category, that's a little bit harder, right? But at least it would be nice to just know one CT scan. And I would pick an age, like I'm not going to pick 20. You're not going to do it 18. The chance of you having lung cancer at 18, even if you're Asian with 3 family histories of lung cancer, it's not going to show up yet. It's going to show up later, and that's why you need the blood test, but that's not prime time yet. But a CT scan, like you saw, like you may still, not you, but whoever, a 30-year-old that has a mom with lung cancer, if I scan them right now, there's a good chance at 30 that they're not going to have anything yet. It's not going to be, the risk starts to bump per age. And I think somebody was asking that. And it's usually 30s, then 40s, then 50s. That age group is the 30s to 50s. It's very rare, and let me know, anybody in the audience that knows somebody, but it's very rare to know somebody, Asian woman, non-smoker, in their 20s with lung cancer. You see that once in a while, but it's usually 30, 40, 50. So again, the family history though is big. Yeah.
So kind of like a follow-up question to the gentleman there about options. My mom was diagnosed with stage 4 lung cancer, and she is actually on the targeted treatment using Tagrisso. So I just wanted, I'm happy to hear you said today that surgery really helps, and even at stage 4.
Right.
And Asian women tend to respond well.
Correct.
My question is, so the target treatment is also known to establish the tolerance or the mutation.
Resistance,
after,
yeah, they mutate. Correct.
After a few years.
Correct.
I don't know how many years, but
on average is 2 years.
Okay. So I wanted to know if there's any options after that.
There is. So that's why you have to. That's why I showed you a picture of Yoko and second opinions. So if your doctor's saying there's no other hope after you become resistant to Tagrisso, you have to get another opinion.
Okay.
Because as long as she's still susceptible, meaning responding to Tagrisso, you keep her on that. And keep her on that till the cows come home, forever. As soon as they start progressing, which they eventually, she may not for a long time, but even if she does, that's when you need to get a second opinion. What they should do is then what they'll do is they'll rebiopsy and they'll resend new, what's called next biomarkers or next generation sequence to see if there's new targeted therapy that you can go on. Plus, like I told you, we had 35 new drugs in the last 5 years. If there isn't that, and it's still localized to a certain area, that's usually when you start to think about a surgeon and a radiation oncologist. But if they don't refer you that, because it's got to be your oncologist that has to refer you. I'm not going to know about you because she has stage 4. So you have to have like-minded or open-minded, and there are out there. Stanford has them, Davis has them, but not, whatever UCSF, they have to recommend that. If they don't, then you tell your mom, I want a second opinion. Whether it's MD Anderson, wherever you want to go, because there are trials and there are studies even ongoing right now, not in Asian women, but that are showing a benefit with stage 4 disease now, and that's in the population that I told you do worse, the white male with it, or the the Black African American with stage 4. And Asians is even better. We just don't have a clinical trial for that, but I've been doing it now for the past several years, and we have oncologists, even in the Kaiser system, that are aggressive about that. I get referred a lot of stage 4 patients, but that are progressed after it. But guess what they say? Do you think they actually do it? No. A lot of the women are scared. They're scared. It's an Asian cultural thing that I can't get back. One of them I know is she's even a physician. She doesn't want to have it. She's worried because the surgery usually gets bigger, right? Because if it's already stage 4, I got to take out more lung than just a little piece. And they'll tolerate it. That's what we do. We've done that before, but it's scary. And so I am fighting that stigma of, I have stage 4 disease, I want to die. I don't want to do a big surgery and have because I'm going to already die. And I'm like, no, you're not. Well, the data shows that surgery is not helpful for stage 4. Well, I'm telling you no, but it's hard to convince people to do that.
So you're saying surgery is applicable even after the initial targeted treatment?
That's usually when we do it. I didn't get deep into it, but you have your family member. It's not initially when you get stage 4. It's stage 4 initial. It's only initial stage 4 if you have, say, what's called oligometastatic disease. So something in the brain, and then something in the lung, something in the adrenal, just one, and something in the lung. Then up front, stage 4, that's called stage 4A. We take out the lung and we take out the brain, part of the brain. We take out the adrenal, we take out part of the lung. But the stage 4 that most Asian women get, which again, this is all new, right? This is too much for you guys. Mesoforte, or the medium kind, they usually develop pleural effusion and lymph nodes on one side. But it's metastatic because it's in all different areas of the lung, but on one side. So then those patients are put on, they get a biomarker, they're put on Tagrisso, and then they stay good for 2 years. They don't see me, and that's fine. I don't need to see your mom at that point. It's when they progress off of that, the tumor will start growing back because it's not responsive anymore to Tagrisso. Those are the patients that we're now acting on. Those are the patients that my oncologist will send me the patient. I'll talk to them about surgery. If they don't want to do surgery, the other option you do have, so it doesn't have to just be surgery, is radiation. Because radiation is a form of local therapy to radiate that whole chest. It's just not as effective. But it's less toxic sometimes because you think, well, I'm not cutting you open with radiation and doing that. So it's after. So in your mom's case, it would be only if she progressed, I would think about doing surgery. And again, it's in certain cases. If she had brain, bone, liver, everywhere, then it's not as important for me to do this unless the other doctors were going to treat those other areas that are progressing. And we do that sometimes. And people don't realize that's what we're doing. But these are usually young, educated people that have it. So they're like, I want to stay alive for my kids. I want to do this like that. So they'll do anything. And so they're willing to do all that risk. But a lot of the Asian women that I sometimes have, especially the older ones, are not. There's other reasons for that, but I'm trying to convince some of them because I'm like, even though you're 80, you may live till 90 because it's in your genes to live longer. But they're like, well, I have stage 4 lung cancer. I don't want to deal with it.
I think I'm going to have to try to convince my mom if it'll come to that point because my mom is 88.
Right, but it depends how serious it is, right? The stage 4 surgery doesn't always have to be a big surgery. A lot of times it is. But that's why I tried to show you Yoko. You saw Yoko. She's a little tiny little thing, 80-year-old, right? And I took out all that tumor. I'm not saying everybody's going to turn out like that, but there's a good chance that you will. And she was, on oxygen before I even did surgery. Because that's why we did it, though, because she was on oxygen because the tumor was growing. So do you want to die peacefully, comfort care, and not do anything but be kind of comfortable? Or do you want to try something for something bigger? Do you want to try? I'm the person that's going to try, but I have to realize too, my limits. Not every Asian woman that's 88 wants you to cut open, wants you to cut open. They're like, let me be. That's what I get on the other side is sometimes people are like, no, you're too much. So people like me are more for the people that really want to push the envelope a little bit that, whatever, old or young. So I think it's important at least that she gets that option that I can at least tell her, and then she could reject me and say, no, I don't want to do that or whatever, because I don't want to take that risk or whatever. But at least that she knows that option, which most women don't know they have that option.
Thank you.
Yeah, a lot of times that's financial, feel like, I don't want to be a burden financially to my family, especially, treatment and surgery can be expensive. I didn't realize that until heart attack. And this time when I visited him, he's like, I don't want to go through the same thing, too much money. Next time if I do, just let me go.
Yeah, but insurance, a lot of times insurance, a lot of us have insurance. If you have insurance, it'll be covered though.
Yeah, but still they don't want the family, my dad personally, he didn't want me to spend so much time on that.
Right,
like
yes.
the stress you go through.
Yeah. That, you're right, that's absolutely true. I can think of 2 of my Asian female patients that aren't undergoing because they don't want their family to like take care of them afterwards. Which I understand, but it's, yeah.
Doctor, thank you so much for your sharing. And I'm asking this question for my mom. So she was doing lung cancer antibody testing in China in a hospital. And she tested for 7 times, and one of them is positive. I think it's called GBU4-5 or something. And the doctor told her, confirmation as lung cancer, it just means she's very high risk.
Yeah.
So what can she do, to make sure she's healthy, and if she eventually do get lung cancer, how does her?
Right. So that's the con of getting the downside is when you get these kind of new antibody level tests that we don't know what to do with yet because there's no data to show that, because this is not your classic EGFR. It's kind of a high risk kind of novel thing that maybe associated with increased lung cancer, right? Which hers is. So if she's really concerned, the main way to back that up is with a CT scan.
Okay, so should she do the CT scan every year, or?
That's the problem. We don't know the answer to that, but if you really want to have the best shot of catching something early, the only way to be completely effective is to get it every year. It's a low-dose CT scan, so the chance of you developing cancer from the radiation would be very, very, very low, so you're okay. You just got to make sure they give you the low-dose CT scan, and that would be the recommendation.
I just want to be mindful of everyone's time. Dr. Velotta and Angie, are you okay with answering one more question? If there's more questions.
Thank you. I hear that word CT scan a lot.
Yeah.
So my wife has been getting, she has been getting the chest X-ray. Please, she has some cough, and they'll do it. She didn't have to ask for it.
Right.
So what does it take to get a CT scan, not as a cancer screen for her?
Right, if you have symptoms, right? So that's what you're saying. So yeah, you're right. That's the issue, is that at a minimum, they'll get you this X-ray because it's cheap. It's a couple dollars, and it's super easy, right? And it's no big deal about billing. Everything gets referred to that. The issue with her, if she's still having symptoms and getting multiple X-rays, that's when her doctor should be getting her the CT scan.
So you should ask to it.
Yeah. Because if you keep getting coughing and symptoms, and you keep getting X-rays, I just told you that the majority of times, right, 80% of the time, you're not going to catch it on an X-ray. In fact, one of the studies that I showed, they compared people that got yearly X-rays with yearly CT scans. It's the yearly CT scans that make a difference. Yearly X-rays doesn't show it all. And I already know that clinically too, but there's research to show that. So she keeps getting X-rays, you won't see it. It's the CT scan. If there may not be anything wrong with her, but if there is, it's the CT scan that's going to show it.
She's not getting X-rays all the time. I'm just saying she got one a couple months ago.
Right.
She doesn't get it very often, but for the future,
if she still has it again, you would want to get the CT scan. If she still has cough or shortness of breath and stuff, and it's like chest related and stuff, the X-ray often won't show it. It's a CT scan.
If they ask the doctor, they should consider it.
They should consider it. Yeah, you say, hey, look, I was already back here. I was coughing. I'm coughing again. I've gone on my inhaler, done all that stuff. You got me the X-ray, didn't show anything. I would like to get a CT scan. That's totally reasonable. And that's not screening. It's unreasonable if you guys go into the doctor and say, hey, I'm Asian, I'm 30, and I want to get a screening CT scan in the United States. They're not going to give it to you. They're going to say no.
Thank you.
Yeah.
Last question.
By the way, Dr. Velotta, do you mind going to the previous slide? I think people want to know how to follow you.
Oh, that's exciting.
We got more fans. So, Doctor, just a follow-up question. You mentioned some tests like the stool test for colon cancer, et cetera, et cetera.
Yeah.
So, is that the same efficacy as the colonoscopy?
It is.
It is?
That's the benefit. We showed that. Kaiser actually showed it, not me personally. The fit test. That's why at Kaiser, I know it's different everywhere, but at Kaiser, we actually do not send you the thing for the colonoscopy. We send you the FIT test. If the FIT test comes back positive with blood, then you go to colonoscopy. Otherwise, you just go to FIT test.
FIT, F-I-T?
Yeah, FIT. It's a stool test. We call it FIT, but it's just the type of test, but it's basically, you send a little, it's like a little card that you poop on a stick, and you send it in, you mail it back in. So it's the fecal cold stool blood test, that one. That's just as effective as doing.
So if that test is negative, you would not send someone to colonoscopy?
Correct. That is the way we do it at Kaiser, because we showed that. We were the kind of leaders in that, but not everybody has to adopt that. You can either do that, or sigmoidoscopy, as you know, every 5 years, or the colonoscopy. But we found that the FIT test, or the fecal cold blood test, was equivalent to that, if not better, and you save all this. Because we could, basically Kaiser was like, we launched a study on that because everybody then, right? Everybody 15 over was coming in for colonoscopy. We couldn't get them all in. And so we're like, we did this research, we published. So like right now, like if it was me, right, I'm not 50 yet, but if I turn 50, actually now it's 45, right? Now 45 for screening. I don't know if you guys all know for colon, regardless of who you are or Asian or whatever, I would do the stool test. If the stool test is positive, then I would do the colonoscopy. I would never go, or sorry, not never, but for me, I would not go to the colonoscopy first.
Now, what about other types of tests for pancreatic or lung or other cancers? Are they still similarly effective blood tests in place of PET scan or CT scan?
That's what we're studying right now. Pancreatic, no. Lung and colon, those are the two best ones right now that they're studying. It's a pan study that they have, lung and colon. Grail's working on it, a couple other big companies that are, these big pharma companies are working on it. That's the clinical trial that's going on right now. You can enroll in a clinical trial, get your blood tested for lung and colon. You won't know the answer, but they'll test your blood, and they're accumulating thousands of patients now as we speak. So that's the one that's the forefront. It's colon and lung that are the most accurate right now.
That we can volunteer to be part of the test group based on one of the slides.
Right.
Yeah. You can do just a general Google search, or you can set up your Google alert for like clinical trial for XY cancers.
They have it right now. They have it. They're enrolling right now on people like because it's industry funded, so it's through industry. But they have because the industry all those companies are here actually in Silicon Valley, so they're actually doing that study. We currently are going to be getting the one for colon and lung. So when that study comes up, Kaiser will have one up too. But we just started that. We just got approval for that. So we're going to be testing that out too, because you're right. That's what we're interested in. That's what I didn't go into. That's what I'm really interested in, right? Because I know I can't get you guys all the CT scans. It costs a lot. Yeah. Plus the radiologists have to do that. You got radiation or whatever. What if I do the blood test? So we are into that, but it's not prime time yet. That's what I'm getting at. If in a couple of years it will be, because we're going to get funding for it. But right now, if you came into that, we don't have that. We don't offer that yet, but we will in about a year.
Right. Last thing I want to say is that I think this kind of outreach that you guys are doing, they're very important in the Asian community, because in the Chinese community at least, maybe Japanese experience as well, cancer is not something to talk about. Yeah. Culturally, especially for immigrants, right? Yeah. A lot of us grew up overseas, not in America. So we don't want to talk about death. And when we know something that's, say, cancer, we view this as a death sentence. That's not really accurate. A lot of people have cancer and they survive with surgery treatment. So I really commend you guys to do more of this type of outreach to the Asian community, maybe radio, maybe social media, maybe to senior centers, or whatever engineer association. We really need to have voices like this, people like you, to do some outreach in the medical field so that Asians don't feel ashamed to talk about cancer, to find out diagnostic methods. I think that's really important.
Thank you.
We need to get Dr. Velotta.
I think it's the Asian channels, that's the problem. All the channels I'm on and stuff are your classic kind of like, Caucasian, millennial, all that stuff. So it's getting, a lot of that population knows it well, but that's not the population being affected, it's you all being affected, and you're not on the same channels that I'm on, and so you're right, that's Andy's job.
We need to get you online, line for Taiwanese community, Japanese community, and Xiaohong.
Like streaming, maybe live streaming.
Yeah, but that's why we need more people. Maybe that's why there are more people than just me, right? But that's why it'd be nice to have. That's why my faults, or I have a lot of faults, but I'm not as relatable, I think, to this community, because they they see male. It does help that I'm Asian, but just the way I speak and the language and the outlets that I'm on, right? Like the IKT, whatever, Channel 26 and all that stuff. Like I'm not. I could do that and I could send that to you, but it has to be translated. Like I can't understand anything. So I do feel like that's where my limit is. So what I try to do to combat that, to help that, is hire people that do speak the language, that know the culture better. Because I can't even say I know the Chinese culture super well, right? I'm Japanese American, 4th generation, right? So, but I've had that help. But I'll tell you, even with that, so I'm gonna keep going, because I'm gonna keep working on it because you said that, but even then, my 2 younger female, they speak Mandarin and Cantonese. They say even when they're doing these outreach for the lung cancer screening, this is the men one, this is not the female one. We're doing one for men that smoke. They're having trouble. Even though they're like, because the men are just like, maybe because they're women, I don't know, the men are just like, I don't want it. So.
Lack of awareness and also stigma. Because people feel ashamed.
Yeah.
That's why you need to be out there. If you're a doctor, this is the knowledge. Get on live streaming.
So you're saying keep it up.
And Dr. Velotta can stay behind for 20, 30 minutes, so you can socialize with the audience.
Sure. Yeah. So I think that would conclude our talk today. It's such a privilege to have both of you here with us today. And that's the 7th of our episode from BACCS. Next week, we're going to have another session in Saratoga Library, and it's about Cultural Revolution and its historical context being misused in modern discussion. So please find out information on our website, which is baccs.org. You'll be able to sign up and follow our future events. And that'll be all. Thank you all for being here.